Welcome, Professor Babu. Couldn't resist that. Thank you, everybody. So when should rib fractures be prepared? This is the Controversies of Thoracic Surgery session, which I'm not entirely sure it's appropriate for this position. But so quick disclaimer. I did this in the Thoracic Forum. I got a vague smile from everybody. Nothing to declare except I do work at St George's Hospital. And we all get on. That pink box is actually our office, just to emphasize that. So contents, I'm going to run through a little bit about the background of rib fixation, a little bit about the evidence and indications, approach, and approaches and techniques. So 25% of our patients, a quarter of our patients who present with thoracic trauma in the UK will have a rib injury as part of their sequelae injuries. We're all very aware of the importance of the chest wall dynamic and the fact that it can affect respiratory function and associated with significant pain, leading to other complications, including atelectasis and pneumonias. And we're also very aware that patients with significant chest wall injuries, rib injuries, fractures, if they end up on a mechanical ventilator, particularly in the first 24 hours following their traumatic injury, 12% of those patients will die. And that's based on quite a robust data coming through such databases as TARN. Survivors of rib injuries, a little less. The qualitative data on this is a little less clear, but it appears that they do have a significant quality effect on their lives, particularly if they have significant chest wall deformity associated with their injuries. And we all recognize there's actually a paper that goes back 20 years, which only had a small number of patients, but it demonstrated the number of rib injuries, the number of rib fractures actually was tied very closely to the mortality in patients who were mechanically ventilated. So there's certainly a good, strong background interest in trying to support these patients through traumatic chest wall injuries. So this is that was published something back in 16, 18 years ago now. It came out slightly from a curveball produced by NICE around the role of metal rib fixation for patients with rib injuries. And it was actually based on a very small number of patients. So often I have a background, where's Mr. Dunning? Me and Mr. Dunning were NICE reviewers back in the day, a long time ago now, and we have an interest in systematic reviews. And you often find when you dig into things, you often find the evidence. Professor Treasure's in the audience. We'll discuss that in lecture, I'm sure, over a coffee. You often find when you dig into these robust systematic reviews, etc., the quality of the data is often rather poor. And this is actually a NICE guidelines published in 2002, based actually on 37 patients generated from a study in Japan. So it kind of reflects the quality of the data occasionally. It's always worth digging into these sorts of publications. Anyhow, so that sort of set the scene back in 2002 that we should be looking at fixing our patients who are on a mechanical ventilator with flail segments, that they should have early intervention to fix the ribs. And this obviously tallied with a driver that the technology, the metal fixation systems that were coming online at a similar time, and I suspect that's not an accident. Since then, you've got this massive sort of increase in publications around, this is just doing a quick PubMed search last December, around rib fixation, articles being published, and it's certainly an exponential increase in the number of papers on this topic. More recently, in 2015, the group here published the first Cochrane review on 3 studies specifically focusing on 123 patients, and it demonstrated that there was no clear evidence of difference in mortality between treatment groups. This is patients who were treated conservatively versus patients who had surgical intervention. However, there was some certain improvements in the risk factors of developing some of the cardiopulmonary complications that we are all very aware of, and including such things as mechanical ventilation, length of stay in ICU, etc. So again, we started to see through these sorts of systematic review processes evidence supporting the role of rib fixation. The most recent and largest best quality data I could find in preparation for this talk is from this group based in the Netherlands, and the Netherlands has a particular interest in fixing ribs through Michael Benneman's work. And this was probably one of the largest sort of review articles I could find, dealing with around 5,800 patients who were described as either flail chest or multiple rib fractures, and that caused some issues with definitions, receiving either rib fixation or non-operative treatment, conservative management. There clearly is some issues around where's Eric? We need a statistician here. There's clearly issues around the type of meta-analysis you're generating and the quality of data in and the quality of data out. However, it showed there was evidence, particularly around mortality in patients who underwent surgical intervention, that they benefited from rib fixation, as well as other elements, including the role of shorter lengths of stays in ITU, shorter periods in hospital, as well as some of the reductions in cardiopulmonary complications that we're aware of. However, it did comment that it was unable to assess further patients having multiple rib fractures. And I think that one of the problems, and this is a perennial problem with these studies, is that there's quite a lot of heterogeneity and issues of definition about numbers of rib fractures and what constitutes a flail segment, etc. So really, in conclusion, it felt it was beneficial, but did have a rider that there was insufficient data regarding what type of patient would benefit from multiple rib fractures. And that I think remains to some extent an Achilles heel in approaching these sorts of patients. It's a question I often get asked by our trauma group. Which patients should we be referring to you? I say all of them. We decide, and a lot of it's decision-making in front of the patient at the bedside about what we decide to offer a surgical intervention to. And that's really supported by this lack of data around which groups of patients. Specifically around the timings, this is an interesting one. This is actually, of course, I will get there, the title of my talk. The most robust study I could find dealing with the specific issue of optimization comes from Tom White's group in Utah. Utah seems to be the center of surgical rib fixation for reasons which I'm not entirely sure, but suspect it may be related to industry, but that's me being cynical. And they looked at a study where they looked at 4 trauma centers within the Salt Lake City area and looked at timings of intervention. And they looked at different groups of patients having intervention at different time periods following their traumatic chest wall injury. And they used various outcomes, which are standard outcomes in this group of patients, including prolonged stay, mechanical ventilation, ICU stay, etc. And then again, they used various attempts at complicated statistics to try and work out whether this data was, essentially they tried to clean up the data. And what they found was that a third of patients in each group represented, so a third of patients got their surgery within 24 hours, within 48 hours, or within 10 days. They found that there was a significant shift across the study period to earlier intervention, which I think we could all understand why that would be. And they also found there were some differences in around these sorts of categories when they compared the study across the 4 centers. So what they concluded in some ways was the injury severity score, interestingly, didn't seem to make such a difference to the time of the surgery, which is an interesting finding. The median length of stay was longer in patients who had their injuries for a longer period of time. And if you do rib fixation surgery, that becomes quite obvious why that would be. And then they also found various significant indications, including, again, cardiopulmonary complications such as pneumonia, length of stay on a ventilator, and avoidance of intervention because of that, all reduced by early surgical intervention. And I think the point really was go in early, fix early. That was kind of the point of Tom White's conclusions. But of course, this is just, if anybody was at the Thoracic Forum recently, there was a conversation around the role of the thoracic surgeon within managing these patients. This is a slide I borrowed from John, and it really highlights the issues. And one of the issues in our own centre is timing. We are predominantly an oncologically based service, so we are offering these patients inpatient surgery, urgent surgery within our limits of our elective operating lists. And that is an issue which becomes important. And certainly, I think who is doing the surgery is an issue within this kind of framework. So if we're being asked to operate on these patients within 24 hours, where are we going to do that operation when we've got an elective list of cancer patients to work through the following day. And certainly we're looking at, in our own institution, the role of CPOD lists, which is dedicated to the thoracic surgeon. If you go onto a CPOD list, anybody who uses CPOD lists know that you're fighting off bum abscesses, etc., to try and get your operation done in time, and it's quite an ask for a service which is fundamentally oncologically based. So what sort of ribs are we fixing? So this is a nice paper generated by this group here, again through Salt Lake City, the Center of Rib Fixation, and it looks at different recommendations, and certainly the number of ribs fixed is an important indication, as well as mechanical ventilation or need for mechanical ventilation. Symptomatic non-union essentially means pain, and certainly in our own experience, numbers of rib fractures, pain associated with rib fractures, and displacement, deformity are the three strongest indicators for needing for surgical rib fixation. Now, we've introduced a serratus anterior block policy within our unit, which has changed one of those indications quite significantly, and we're hopefully going to be publishing on that fairly soon. And pain is no longer necessarily the biggest driver in that first 24 to 48 hour window. So interestingly, with a bit of focus, we're now focusing on analgesic protocols, and that may affect surgical intervention at an earlier stage in this group of patients. So this is Michael Benneman, who I touched on before. He's produced some guidelines around when and when not to fix, and using, again, all of the usual indicators that we were referring to earlier: flail chest, number of rib fractures, ventilator dependence, and this, but B and C. Now, John Edwards had a real good go at trying to classify rib fractures through a prospective trial that unfortunately didn't receive NHA funding around trying to classify rib fractures and trying to get an understanding of rib fractures. And certainly for development, it's rather simple. It's just a degree of displacement, i.e. the level of deformity on the X-ray or CT scan. So, and Benneman went on and drew up an algorithm to try and allow guidance around what sort of patients should be offered rib fixation based on the parameters we've already touched on, including age. And I find age is actually quite an important consideration, and certainly I've experienced old elderly ladies having falls, having rib fixation, where you're plating very osteopenic ribs and you're finding that the plates are simply not holding. It's not a common problem, but it does occasionally happen. So I think age is an important element which he adds to his algorithm. So just a quick précis about things that we should all be aware of. Chest CT scan is now mandated on patients having any form of thoracic trauma as part of a trauma series, and one of the conversations at the Thoracic Forum was about protocolizing everything, and being very involved in your trauma network protocols is really important if you want to be at the table for this sort of work, and if it's something you want to develop an interest in. In that regard, we have CT reconstructions as a standard of care for patients presenting with multiple trauma, including thoracic trauma, and certainly that helps delineate and work out what you're going to do and how bad it is. Occasionally, transaxial images can be a little bit, they don't always provide the information that you want. Our approach is pretty standard. We work as a surgical group, and we have the same standard process for each patient, which, being keyhole surgeons, we feel very comfortable with keyhole surgery. We put a camera in, we do an assessment of the pleural cavity, lung and diaphragm, and we're presenting some data around incidental diaphragmatic injuries in a group of patients presenting otherwise with multiple thoracic trauma. This is a great video. You're most welcome to borrow it if you're talking to orthopedic surgeons at any point in time about their interest in fixing ribs. Sometimes it puts them off slightly, which of course is the point. Anyway, so we go on and do a placement of a paravertebral catheter at the time of the assessment. That's done intraoperatively and intrathoracically. It allows us to position our paravertebral catheters in a most appropriate position, and it can be done thoracoscopically, and you guys are all very good at doing this sort of thing. So again, it allows us a very nice standard approach, both in terms of analgesia and fixation. We do a pleural drainage, formally of course, and then we do an assessment of the rib fractures and location. What I've found, and I'm sure you would agree with this, when you've got very heavy patients in front of you, often assessing them internally is easier to see what degree of rib fractures they actually have. I find sometimes it's quite hard to work out where you're going to make your cut, and I've certainly seen, in my experience, patients having cuts from stem to stern, and you kind of ask the senior surgeon why he's doing that, and you usually get the usual big surgeons, big cuts, blah, blah, blah. But actually, because they don't quite know where they're going to place their incision. So by doing this, it does allow you to be a little bit more precise about where you're going to fix your ribs. And of course, people are interested in this area. We're all going on about whether we can fix them internally. It's a bit of a holy grail amongst rib fixation surgeons. It's not there yet, and I can see a few representatives in the audience who may have some comments about various devices on the market, but there isn't any that I'm aware of that currently have a patent. So we do a small thoracotomy. We having assessed them intrathoracically. We do our rib fixation. This is quite an old video, but it just shows us assessing patients having rib fixations in a nice position, nice lateral position. They're not always this easy, unfortunately. And then having done that, we make a small thoracotomy incision, fix our ribs, and this is the same patient. So through essentially, okay, I might be lying slightly, 8.5 centimetre incision, we were able to perform a 4-plate rib fixation. So that's what you're trying to achieve, and obviously the idea is to reduce the morbidity down to a minimum. So quick review, I'm not sponsored, of different products on the market. Synthase were one of the first at the table, and they've produced various products, and I like this one because it's a right-angled instrument that allows you to get under the scapula very nicely. Matrix Blue, which is our favoured instrument of choice at the moment, but we have Synthase as well, is another instrument equipment on market. MedExpert have been around for a long time, I'm sure, particularly the hairfield doctors know them very well. And RibBlock is also another product that's on the market. And recently I was in Abu Dhabi with some German surgeons who swear by their German system, of course, being German. So various devices, and of course you've always got Alibaba. I use it a lot, I'm sure you all do, to buy your kit. I am kidding. And there'll be a lot of I always said the word knockoff. That's not the right word. I didn't mean to say knockoff. There's a lot of Chinese products on the market which do the same thing. So lots of opportunities for you to try different rib fixation systems. Quick advert, Chest Wall Injury Society set up a couple of years ago. Tom White's involved very heavily, and John Edwards is involved very heavily. I strongly recommend getting involved in this group. Thank you, and that's homage, of course, to the man himself. Thank you very much.